If we really had our druthers, I guess what we'd want to do is get veteran patients up here to talk to. The difficulties in doing that are real, and were talked a little bit about yesterday, but it's a shame because they're more important than the trainees. But the next most important group are the folks up here. Why are they important? Not just because they're consumers, but because they're going to have to carry on what the faculty, which is graying, at least most of it, some of it's younger, and really finish the job, because this job is a generation job. Is that working?
Yep.
All right. This job is, notice, it's on. It's not working, so to hell with it. This job requires, 10, 15, 25 years of work. We're not going to change the culture of American healthcare and the culture of American health professions education overnight. And so these are really important people. So be nice to them. That doesn't mean don't ask them hard questions, because no, I'll just stick with this. So be nice to them, but ask them hard questions. So what we're going to do is, after we get each person briefly to introduce themselves, I'm going to lead off with a few remarks and a few questions to get the process going. And the panel is going to answer those questions in one way or another. Or we'll just stand here looking at them until they do. And then we're going to open it up to you folks. So what I want you to think about is, what really are the key questions that trainees, by answering, can help us move this project forward. So, let me start. I was given some information. And I was given information by two people that I need to thank. Annette Gardner, who has done some analytical work on some survey data that she's collected from trainees, and from Traylor, who collected some more information from at least some of the people on this panel. And rather than going through all that, let me summarize what I think of the information. It is wonderful qualitative information. It's also very useful information with regard to what I like to think of as the lower levels of learning outcomes, the reaction of people to events, satisfaction surveys. We are addicted to satisfaction surveys. Why are we addicted to satisfaction surveys? Because they're easy. They're easy to do. But they don't really provide the kind of crisp information. Hello. The kind of crisp information that we need. So that's at one end of the sort of learning outcome scale. At the other end is performance in practice. And I'm going to come back to that, but I wanted to mention the issue of what that is, how we measure it, why we measure it, and how important it may be, and I believe is, as an intermediate outcome to what we're really interested in, and that is improving health and improving the system in which healthcare is delivered. So it's health and system outcomes that are the real outcomes that we're interested in. But it's very useful to have a learning anchor outcome, but satisfaction just by itself is not sufficient. So in the panel, thinking about the questions that I and you all are going to pose to them, I would ask them to think about issues around not just satisfaction, not just knowledge, not just skill sets, but really how they think their performance in practice has changed, and whether they can really give us some insightful process and measures around that particular topic. So, with that by way of introduction, let me start with the young lady to my left, and we'll just scoot down the line, just briefly, who you are, where you're from, and a little bit about your profession, I think.
Hi, everyone. I am Courtney Bancroft, coming from West Haven. I'm a psychology postdoctoral resident, working specifically with the addictions population and also with the other primary care populations in the COE.
I'm Joseph Horner from the Cleveland VA. I'm a postdoc in clinical psychology and working in primary care.
I'm Dan Doan from the Seattle VA. I'm the chief resident in the program there, and also have a position as a clinician teacher fellow within the COE.
I'm Tom Clark. I'm from San Francisco, and I'm a resident in internal medicine.
I'm Maria Michael. I'm a second-year internal medicine resident at the Boise VA.
I'm India King. I'm a psychology postdoc at the Boise VA.
My name is Christine Hennish, and I'm a nurse practitioner resident also at the Boise VA.
I'm Anna Struhler. I'm a nurse practitioner resident in San Francisco.
Hello, everyone. I'm Danielle Alstrom. I am the chief pharmacy resident over at the Boise VA.
Hello, I'm Matt Sparks. I'm one of the nurse practitioner residents from the Cleveland VA.
Good morning. My name is Sarah Lipkin. I'm one of the West Haven Nurse Practitioner Fellows.
I'm John Thomas. I'm a third-year medical resident at the West Haven VA.
I'm Leon Bromley, the nurse practitioner resident in the Seattle VA.
Hi, I'm Carlin Nealand. I'm one of the nurse practitioner fellows from West Haven. And I have 2 mics.
Is that it? Does this work? It's working, so I can hand this back. Terrific. Can you hear me? So the first sort of frame that I wanted to introduce, and by the way, the panel hasn't seen these questions. Only I have seen these questions. So I wanted to get a little bit of motivation. And so what was your primary reason for joining the program? And how do you think it's going to influence your ultimate career? Because you're pretty close, all of you, to your final career choice. So could you reflect a little bit on that? What was the motivation for doing this? Why did you come to this? This is awful. Why did you come to this program? And how's it going to influence you? Please.
So, like I said, I'm from the Boise VA, and prior to starting this program, I was an RN in their ER. And Melanie Nash, who was the outgoing director of our program, she went to Gonzaga just like I did. So I started talking to her about it, and I realized what a great opportunity it would be to actually go somewhere where I had more than one person that could help me gain my skills and stay within the VA, which was something I already wanted to do anyway. So to me, it seemed like a no-brainer. And once I started talking to my classmates that had a job in the real world right after graduation, I've just listened to them. I don't think flounder is the right word, but they seem to not have had such a great experience the past year that I've had. So I'm eternally grateful for the choice I made to stay here. And my plan is to stay at the VA after this residency. I don't ever want to leave.
So that's sort of interesting. You're referring to mentoring and having the right mentors, and that I think we all know is an important issue. But I wanted to pick up on something else that you said, which you passed over quickly, but emphasized at the end, and that is you wanted to stay in the VA. Tell me why you wanted to stay in the VA.
I want to stay here because I enjoy taking care of our veterans. But not only that, I think that the group we've assembled is amazing. Everyone genuinely cares about the patient population, and they go out of their way to help them on a daily basis, whether it's the residency people or the pharmacy, the social workers, psychologists, anybody, they just go out of their way. And I enjoy the fact that every single day it's a learning opportunity, whether I just have to seek it out. It could be with my neighbor. It could be at the journal club. It's just a never-ending system, and I love that.
Okay, so part of it is an obligation to those who have served and a passion for giving back to those individuals. It's something that I think again, the room would endorse heartily as an important reason. But the other implication of that, which perhaps some others of you can reflect on, is that the learning environment inside the VA is in some subtle and perhaps some overt ways different than the learning environment, at least in nursing, in the private sector, I'll call it, but external to the VA. So let's sort of take that little bit and build on it with some of your colleagues and thoughts about your motivations.
So I can speak to, this year I've been in the process of looking at positions at other community sites in addition to the primary care system at the VA, and that learning environment that you talk about, I think, is the primary motivator for me to want to stay at the VA. The community sites, while I appreciate the work that they do, are leagues behind in terms of the forward thinking, the types of care that they're delivering. Almost across the board, it was sort of a very traditional way of delivering primary care, which contrasted with my experience at the VA. Just felt like a completely different practice. So I'm also staying with the VA next year as faculty at Seattle, and a lot of that had to do with the type of primary care that we deliver.
So the healthcare delivery system, despite all its warts and problems that it has across the country, not just in the VA but outside of it, is in a comparative sense rather different than in the VA compared to the external environment. What do others think about this?
So for me, that was one of the main reasons why I wanted to do this residency. There's a really unique opportunity, especially within psychology, to begin to integrate into primary care, which is not happening. And if it is happening outside, on the interviews that I have been on, they're very impressed that I've actually been able to have the experience to work on an integrated primary care team already. So I see, healthcare in general in our country kind of in crisis, and whenever there's crisis, there's always opportunity. And I think this is a great. I've been clinically trained as a psychologist prior to this, so it was an opportunity for me to get specialized supervision on behavioral health issues, working together with nursing and pharmacy and medical residents as well. So I think that whole forward thinking and kind of ahead of the curve nature that the VA training provides is really what pulled me into it as well.
So this seems to be a theme sort of emerging, and we can't go through every individual or we won't get to other material, but one sort of follow-up thought from what I've heard so far that I'm sure has bubbled up in your minds and the audience too, is the issue of how your colleagues reacted to this. What did they say? Were they happy for you? Were they horrified for you? I mean, how did you rationalize this amongst your colleagues? Because you talk the whole time to folks who aren't doing this. So I'd be interested in some thoughts from a couple of folks about that.
So, you can go first.
Hello?
Yes,
I'm
you
on.
got it.
Okay. So I was just going to kind of take a step back because when I applied to this program, I think it was very much less about interprofessional education for me and more about more training. I'm a nurse practitioner fellow. And how the heck would I know what interprofessional education is? Like, let's be honest, from a nurse practitioner program, that was not, what was driving me to be part of this. What was driving me to be part of this was the fact that I graduated and I wanted to learn more in an environment where I was supported. So how are who's going to come to your fellowship? It's nurse practitioners are going to come because, as a lot of nurse practitioners have said, we never talk to our colleagues and don't hear back, man, I wish I could have had a residency program like where I was more supported. So that's why people originally, I think, choose to be participating in this. But then to piggyback on kind of some of the other thoughts, the reason that I wanted more training, nurse practitioners, I think, graduate prepared to provide very competent care, but at the cost of a really high burnout rate. And as one of the other fellows down there said, I talked to friends in the outpatient world who want to retire, and they've only been working for, a year.
Sounds like a pretty good deal to me.
So I think when I also applied to do this, I was really seeking sustainability. We've self-selected to be part of primary care because we think primary care is important. But as somebody made yesterday a remark about how we're the people who stay late until 8 p.m. because we do the best for our patients and we really work hard, that's not a good selling point for primary care. And I think that's a big problem. I think that's a reason that nurse practitioners, that physicians, nobody wants to do it because it's not instead repackaged as innovative and a team-based approach where people can have good quality of lives and provide good care. And so after applying to this, because I wanted to be sustained in a profession and get more education, and now being immersed in interprofessional education, I guess to come full circle on that, I'm finding that to have a sustainable job in this, I need my colleagues in social work. I need my colleagues in pharmacy. I need my colleagues in health psychology. And I need to know how to utilize them to inevitably provide a better experience for the veteran who I'm serving and for myself as a provider in primary care, and to hopefully make this a career that I'll want to be in 10 years down the line.
So your colleagues were envious of you.
So I think in the end, I think a lot of people are envious of the opportunity to get this extra experience and extra learning that otherwise, it's considered kind of a luxury for us. So I think.
So you raise a very important issue. It's funny in these discussions that are open-ended. You never quite know where you're going to go. But you said something very important, and that is that the nursing education system itself needs reform. Forget the team-based care, forget the interprofessional, forget the quality improvement, all of which are important, obviously. But you're not getting enough education, or at least enough education of the type that you think is really important. That implies that the intraprofessional component of nursing education has some deficiencies. And I think we have to be realistic and accept that that's the case. And I can tell you...
Can I comment on that? I'm sorry, I know that you're continuing on, but maybe somebody else could also comment who's in this discipline. But I know, I don't want to get my statements misunderstood. And that being that I think that nurse practitioners are trained in a way that makes them competent to provide very good care. But after graduation, when you sit next to somebody who has been through Medicaid, provided this opportunity to then have 3 years of residency, and I'm sitting next to someone who's a PGY3 who's still precepting every single one of their patients, and as a nurse practitioner graduate, I would not be doing that unless it were for this opportunity. There's definitely a discrepancy in postgraduate training. So I just wanted to make that clear.
Well, thanks for the correction. So that the more advanced forms of training, say postgraduate, left something in your mind to be desired. And the reason I picked up on this is that the Office of Academic Affiliations has actually put a lot of resources in recent years into both post-baccalaureate education and postgraduate education of nursing for itself, as it has in mental health education and so on. So this component, and the reason I belabor this is Stuart was talking about intraprofessional as well as interprofessional education. And I think that there are deficiencies, certainly in my own field, that is a physician, in physician-based education. So I'm not picking just on nurses or any other profession. But we do need to pay attention to that, because those issues need to be addressed in a major way. And this kind of program creates the opportunities to think through some of the intra-professional. But I speak too much. So others who are thinking about this, how have your colleagues reacted to this?
So, so one thing that I was going to say is it's been very clear to me when I talk to other psychologists who are postdocs who are not affiliated with the Center of Excellence, honestly, how jealous they are of the experience that I get. And one of the things that I love about being at Boise is that, you know, we are sort of like in this soup training together, very much so. We're all in the same primary care team, and we're all mucking through this together. And it's like I have two colleagues on either side of me, and whenever they're in clinic, we're like walking down the hallway to each other, we're staffing cases, and just by virtue both geographically of being in the same clinic, I think that makes a difference. But then all of our trainings are together. We go to journal clubs, we do stuff like this together, we do stuff outside of work together, and I think that is huge to have the support of another discipline, not just in the training, but also just in team building and in life. And I think that's what I want moving forward. I want that.
So the reason I'm pushing on this issue is the issue of recruitment. How do you go about creating a new workforce? Well, one way, a new clinical workforce, one way is you have different educational and learning opportunities. And we talked about that a lot yesterday. We'll talk a lot more about that in the next couple of days. But you've got to recruit people to that. And so the VA secretary made a decision when he joined at a time of relative crisis or real crisis in the VA to go out and recruit. And the way he did that was to go and talk to medical schools predominantly, but some nursing schools as well, to try and encourage people to come work in the VA. But he's missed the point. The point of the spear is you folks. Why didn't he come and talk to you folks and get you folks to give him ideas about going to talk, not to the deans, not to the senior faculty, but to the trainees, the workforce of the future? So has the VA secretary or any of his representatives ever come and talked to you about the importance of this program? I think the answer is no. Correct me if I'm wrong. That's an enormous missed opportunity, and I want the Mr. Secretary to understand that is an enormous missed opportunity. Because as we talked yesterday, you folks from the bottom up can really create the dissemination and the passion that's necessary to recruit people to the VA and generally change the educational system. So I think this recruitment issue and your role in recruitment is really important. And so I would end this part of the discussion by sort of saying to you all, have you felt that you've had a strong role in your local programs about expanding the opportunities, indoctrinating your colleagues, getting them to come to this environment, either for general educational reasons that we've talked about, or for more specific reasons to improve the VA clinical workforce? A couple comments about that, and then we'll move on to another topic.
The opportunities for leadership that I've found in my program and for involvement in directing it overall have been incredible. A little scary, actually. But with more guidance from mentors, I feel like they are really invested in bringing up new leadership and handing over the program for the future and thinking about it not just within their lifetime, but even the next generation. And we tease and talk to medical students about, so when are you coming to the VA? And trying to continue this tradition and building a very strong culture within our institution. I feel like that's something we particularly excel at, and anyone can if they're really proud of what they're doing and where they're from.
Do you think that would be more effective that you going to sell at your affiliated medical school where your program is based than the VA secretary or undersecretary for health or senior leadership going to talk to the dean of the medical school? What would be more effective?
I think I would probably be infinitely more effective. No offense to the secretary.
I think you would. This has absolutely nothing to do with this program. It's a general sort of truth. and that is that the trainees really are our best ambassadors and our best recruiters for these programs. And so I know all your programs are using you in that sense, and you're doing that out of your own inclination to do it. But please try and get this message across to leadership. You had a comment.
Just something really quick. As our pharmacy residents, were really close with our local university, and I was there at our pharmacy school for about 5 months, just straight on doing academic work. And I ended up happenstance leading these interdisciplinary case studies with all multiple professions for our students. And I kind of was able to educate about what the Centers of Excellence is and what my role is as a pharmacist. And what was really cool is after doing that, I've had multiple students go to our dean and say, we want this, we need more opportunities. And I have tons of students who are requesting to come and follow me over on my iAPACT team, which is huge. I actually have one next week, which is a huge opportunity in my opinion. But it's so cool that they actually go to the dean and say, I want this, I need this. And that's exactly what we should be doing. We're starting it even earlier, not just as trainees, but as students, which is huge.
So I would say yesterday was Cinco de Mayo. I would say revolution. And I'm serious about that. If we go on tinkering around the edges and don't advertise and promote in an assertive, not an aggressive, but in an assertive way, as you're suggesting, we're not going to be able to change the world. And really, this is a job about changing the healthcare world. And that's really what it is. Don't think of it just as a small thing about a better training program. It really is a revolution in thinking about education. So I want to turn, just for a moment, to another topic, and that is what the key elements or factors in your experience have been. And one thing that's bothered me a lot is I sometimes hear from you and from your faculty about the model of interprofessional team-based care that they're utilizing. But if you think about it, there are a number of different models, right? You could be parallel play might be one sort of model. That is, you're all part of the team, but you have your own particular patients. And here I'm talking largely to the primary care providers, which would be physicians, nurse practitioners, PAs. Obviously, the mental health folks and the pharmacy folks have a somewhat different role. But if you think about the way in which the care is delivered in your teams, it could be on the one extreme parallel play, that is, the nurse practitioner or PA sees a particular panel of patients, and sure, they join together in the huddle so that there could be a step ladder, not just two parallel directions, say PAs or nurse practitioners and physicians in practice as part of a team, and some interconnections like a step ladder in the huddle or at the end of day conference or whatever. But another model might be a much more integrated one, in which a given patient is actually followed by both different, a nurse practitioner and a physician, for example, a medical resident, and that they really work as alter egos on the care of a panel of patients. They step in for each other when they need to, etc. So, and there are many models in between those two extremes. But I wonder if you could reflect on what real type of interprofessional integration or lack thereof you've experienced, and what you think about how you would value different forms of that. Looks like you're ready to give us a great answer.
Yeah, so I'm also a nurse practitioner resident. I did want to do this program partly for increased knowledge and more training, but I do think the interprofessional quality of this program was a major draw, and I think it is for a lot of other people. There are opportunities, or I've experienced opportunities outside of iAPACT in interprofessional education, and this, I feel, is by far the most effective one. And I think, to answer your question, what makes it so effective is that it's done through truly integrating trainees into clinics. And that's a big difference. A lot of other experiences of interprofessional education have felt a little sort of forced and have felt just not as authentic. So I think to be able to train in an interprofessional environment in a team-based clinic, be integrated into it, makes it feel authentic, makes it feel very practical. We're learning skills that we can use right away with our team members. And it's meaningful work because I think, there are many situations in which our huddles and our team-based model reflects on the care of our patients. So I think it just being able to integrate it really reinforces how important it is for all of us to be training here.
So from the patient's perspective, what would the patient, he or she, see in the clinic? You're in San Francisco, if I remember from yesterday, right? I mean, what would they see there? Would they see that they had, and I'm going to make this simplistic, two primary care providers, a nurse practitioner and a medical resident, or would they recognize you or the medical resident as the primary provider? So is it a duality, or do you work together, but in essence separately, is what I'm trying to get at?
I think it really depends on the patient. I think sort of the more high acuity and the patients that do require more care seem to be more aware of our team. For example, as a nurse practitioner, I'm there throughout the year, and my resident practice partners are all often on the wards or in the inpatient setting. And so for a lot of the patients who come in on a very regular basis, have multiple hospitalizations or just require a lot of inpatient clinic visits, they seem more aware of this sort of team-based dynamic in that when if they're assigned to one of my resident practice partners, I'll often see them as a backup provider, and then vice versa if I'm away for some reason. And I think that goes also for the rest of our care team, for our RN, LVN, and clerk. Those patients in particular seem to really get to know those staff and know that, when they call the clinic, my RN will take the message and give it to me, or if they write on my healthy vet, they often hear from my nurse first and they expect that. So I think it does depend on the patient, but particularly the more high acuity patients are benefiting from this model.
So you're articulating that different models are important in different particular contexts.
Yes.
Yeah. Is that a fair assumption? And I see some heads nodding. But I think it's an important sort of question, because unless you assume responsibility by one process or another, your maturation of your expertise and your progression through the learning environment is much impacted. So you need to have, at least part of the time, I believe, really primary responsibility. Other times backup may be important. And you said something, I think, very important. You were not always the backup to the medical resident. Sometimes the medical resident was the backup to you. And that leads into the issue of equality of experience. And I think that that's important into leadership and followership. So how important is being able to assume the lead in appropriate circumstances? And I put this to all of you. How important is being able to assume the lead? And even more important, how do you feel that you can fall back? Do you feel that you can fall back in the various training models into followership without disappearing into the background? Leadership and followership. Your thoughts about that?
Is this on? Okay. So I'm a psychology postdoc, so I think in a lot of ways I do a lot of that, of like shifting back and forth. So there are patients who come in who what ends up being the primary presenting issue is actually more of a mental health thing. And then I do feel like the team in general turns to me as the lead and is asking me, okay, India, what do you think's going on with this? How do we want to handle if he comes back in with these sort of presentations again? And then there's a lot of times that I step back and I'm more kind of helping with behavior change to manage diabetes and, more in a supportive role. And I think my experience has been, here that's the team's more willing to see me in a fluid role where sometimes I'm the lead and sometimes I'm very much in kind of the background supporting. which is unique. I will say I've had training experiences in other primary care settings, and it's a lot more rigid. There's not that fluidity, and I think that's something that I would say is unique about my experience this past year, is that that's welcomed. And if anything, it's sought after. There's times when people want me to take the lead and turn to me and say, this looks like this is more your area. What can we do to help you?
Do you agree, or does someone disagree, that this concept of being able to step up and assume responsibility in a contextual way for the particular situation at hand, and also being able to step back without being lost? So the stepping forward and stepping back, I like the term fluidity or flexibility. Is that important, or do some of you feel that that's not a critical issue?
I think it might be easier for some of us, like, for example, maybe pharmacy and health psychology. It's a little easier when the roles are very much defined, but I think it might be a little bit more difficult just from observation and with residents and NP fellows, and I'd love to hear like that take on it, because the roles can sometimes be very similar, or they could take care of similar things. So I think it's easier to kind of step up when you know exactly what your role is, and step back when you know exactly what you aren't able to do. But I think it might be a little bit more tricky.
Well, I'd love to hear that from the medical residents, what your perspective is on this, because in general, the medical residents are going back to an environment that their affiliates, and I'm generalizing here, there obviously will be exceptions, in which they assume the culture of the top dog. Right? And that's what they do. And it's not done in an evil or negative way, it just is part of the medical culture. So that physicians in general, I'm talking now in general, are perfectly happy with teams as long as they're leading the team. Right? I mean, and that's the common sort of problem. And physicians are the 800-pound gorillas in the room. What profession needs the most change for these things to be effective? The medical profession, using that as physicians. And so I'd love to hear, before we go on to my last question and open it up to the audience, from the medical residents about, so how do you comport yourselves at the academic affiliate where there's one culture, and at the VA where there's this somewhat different culture? Medical residents, go.
I think that's really been the crux of my interprofessional education, is learning when it's not okay to have to be taking charge, when it's okay to hand off and ask for help, and appreciate other people's contributions. That's really been the most valuable thing about working in iAPACT. And then when we go out to community hospitals, I feel like that's what makes them want us there. That's what makes us get along with everybody so well. And it makes the nurses love us. We're mostly on the wards at other hospitals, but I think that the respect and appreciation we have for all the different role players carries through, and everybody sees that we were raised right.
You were raised right. Your mama did the right thing. And this is this group of faculty and the people who lead this program are, in that sense, your mamas. And it is important. Any other medical residents want to comment before I go on to John? Are you looking?
Sure.
ready?
Thank you. So there are practical reasons why medical residents might need to pass on the torch in patient care. One of which is simply that we can't be in the clinic all the time. We often spend most of our time on the inpatient wards during residency, so it only makes sense that we would need to have people that we trust to see our patients, and I think the COE is very good at demonstrating that. The other thing that I'd like to reflect on is that so much of what we spend our time on in the COE is building up the different professions. I think we need to build up the MD profession as well in trying to help medical residents grow as much as possible and fulfill their potential, realizing that they have been through 4 years of medical school and then 3 years of medical residency, and they don't want to feel like that training was wasted and that it didn't build up to something. And so if we're trying to attract physicians to go into primary care, we need to have them feel like they're continuing to grow and be challenged and pushed to the limit of their abilities. There are a lot of physicians who have great leadership abilities, and there's a lot of people in other professions as well that have great leadership abilities. And I think that we need to be building everyone up at the same time.
Yeah, well said. John is going to be, he told me, the chief resident for the COE program at West Haven next year. So he makes a very important point, and it's the same point we started with the lady at the end. I forget your name, I apologize. That is, there needs to be work done in nursing education. There surely is a lot of room for work that needs to be done in medical education, and I would say that's true across the health professions. So the final question I'd see if anyone would like to reflect on, and I'll put it in very homey terms, and that is, are you comfortable in your teams asking questions and challenging decisions, with an emphasis on the challenging decisions? Or haven't we got that far yet? Because that's, if you think about it, psychological safety. The ability to question what's going on is an absolutely critical element of a high functioning in a professional team, or any team, actually. So any thoughts? Do you feel psychologically safe? I don't mean scurrying in at the end of the day and talking to your friend and mentor, but I mean in the actual flurry of ongoing practice activities, do you feel comfortable and safe asking difficult questions?
So initially that I think was really difficult for me, but as the years progressed, specifically in the past 3 to 4 months, that's almost something that I think is to be expected of us, is to be open and honest, even with the difficult questions, and if you disagree with someone's plan of care or whatever it may be with one of our preceptors. So I definitely feel very safe, and I know Elena and I have had some discussions about, she thinks one thing and I think another, and I definitely feel like she welcomes that and she expects that of us, and it's encouraged of us to verbalize that.
But she's a nurse practitioner.
She is. She's going to be our director next year.
Yes, so. I understand, and not to say anything about Eleanor, but would you feel equally comfortable in approaching one of the physician preceptors and questioning a management decision?
Yeah, so one of the great things about the Boise site is that as NP residents we can do an inpatient rotation, and I did that. And one of our physicians I was with, she's very strong-willed, very intelligent woman, but it was the same thing. She welcomed my opinion, and if I didn't agree or see what she was saying. So I think across the board, that's something that is accepted and encouraged.
It sounds wonderful to me. Quickly, other thoughts about that, because it's a very important point.
Yeah, I was just going to say, I think it is difficult kind of in the beginning when we're all sitting at the same table, maybe going over a clinical case conference or kind of these learning days where I think at first maybe we feel a little bit timid or intimidated by medical residents who have been through different training than nurse practitioners, or even talking to health psychologists or pharmacists and being like, oh my gosh, this is a silly question, I shouldn't even be asking it. And I think one of the nice things that I've learned throughout this, I do feel like I'm in a safe environment, and now knowing my team, I feel like I can ask those questions that are really important to ask, and I think we're often siloed into a way that we just don't ask them because we feel like they're silly, or we don't want to look like we don't know what we're doing. And this goes both ways. I know we start out with the medical interns, and I think they feel it very strongly that they may need to present as having a lot more knowledge or understanding than they do at that moment. And so I think it does create a nice space where we feel like we can discuss these things together and really work through them instead of just kind of going back into our rooms and looking them up on UpToDate later. So Yeah.
Terrific. So what you're really saying is, by virtue of doing this, and I'm hoping that you all agree, we don't have time to poll the group, but if you all agree, what you're doing is being able to express complementary expertise, because you're looking at something through a different lens, given your professional background, than the other professions that are part of the team. So this opportunity to express complementary expertise openly and freely is really the essence of being able to deliver quality patient care, and particularly patient safety. So these are not trivial sort of little quirky things in team development. If the team means anything, it's around issues like this. So thank you. What I wanted to do was open it to the audience. We have 5 or 10 minutes, a little bit less than I had hoped, but nonetheless. Amber, you had a question.
So I'm curious to hear more about what John touched on with internal medicine residents and ambulatory care. So people spoke about spending much of their time on the wards on the inpatient side. What do we need to do in the COE to attract more internal medicine and other professions, for that matter, into primary care?
John, you're on the hot seat, but so are others.
I would say that mentorship is really important. I think people need to feel as if there will be mentors in their site that they can look up to and that will help them grow and become the physicians that they want to be. I think that's huge. Also opportunities for leadership and scholarship. One of the things that really attracted me to the COE was just the opportunity to spend extra time and do projects and do research and publish and things like that. A lot of people through medical training end up doing academic work, doing a lot of research and publishing, and so I think that would help them continue to build in their professional lives.
Question over here with the microphone.
Hi. We mentioned that we can't have the veteran here today, but I just wondered, I've been thinking, and I'm not at a center of excellence, and maybe even some of you that are there don't have a good feeling for this, but I think you guys as trainees do. The veteran who comes in and is used to, he get used to his PACT team members, so he's got a consistent LPN, he's got a consistent RN, but he may not have a consistent provider. So he may be seeing different residents, he may be seeing different NPs. What are their take on that, the veterans not having, let's say, a consistent provider?
So can you speak for some residents' perception, for some patient perceptions here? What's your sense?
So at Boise, we had a program structure that involved residents from Seattle previously coming out for a year and then leaving again and going back. And then we've recently, in the past couple of years, switched to one where it's the same resident for 3 years. And we got tremendous positive feedback from veterans.
So the continuity issue is important to them.
It was huge. They really appreciated getting to know someone over 3 years. And I think that has made me appreciate primary care much more as a provider, is building that relationship, because that's a huge part of what makes this job so gratifying.
It's hard to get to know your patients unless you have iterative experiences with them, isn't it? Other thoughts about that? The continuity issue is a terribly important one.
For me, I'm unfortunately terribly used to having to say goodbye to patients after a year because our training is always a year, and it is something I speak openly with my patients about, and they definitely would prefer to keep a relationship, just as we all probably would. But what I can speak to is being able to be present. At West Haven, we have what we call a warm handoff clinic, which every Tuesday afternoon the health psychology and pharmacy residents get to sit in while the NP fellows and the MD residents are precepting with their preceptors. And when I have a patient on my panel who's in to see primary care, whether they have a cold or whether they're sick or something like that, the ability for me to just pop my head in and say hello and check in and see if they'd like to keep their appointment for that week or cancel because I realize they're sick or something like that, really I've gotten wonderful feedback from the patients about. They're surprised to see me in there. They're happy to see me, and they say, thank you so much for coming in, you know. So that ability that we have just to be able to recognize somebody on our list and go pop in during that warm handoff time, I think is very valuable and shows the cohesiveness of our team to our patients. You know, we're all talking, we're all there for them. So I think that's a wonderful thing that the COE provides.
You speak to team-based continuity, not being a substitution for that individual relationship, but as a component of the relationship building across time. Other questions?
So just real quick.
Lots of people have questions.
Hannah East, did I get your name right?
Yes.
We spent all yesterday trying to get her name right.
You did right. It's clear you have been in a very supportive environment, which is as it should be and is what you deserve. But have you had any inkling from your experience of where the barriers are going to be after this? And so the question is, you know, and what strategies do you feel you've learned to not just work in an interprofessional setting, but to create one? Or do you feel you've learned that?
So sort of how you're going to lead your own practice, be it within VA or be it outside VA, along similar lines. We have time for about 2 brief comments, and then we need to move on. So.
I'll be quick. From pharmacy's perspective, I can say our scope of practice it's like a 180 in the VA compared to outside. And going to other facilities, whether I'm just shadowing or trying to help out other students, it's difficult, I will be honest, because it's just so different. What I really do is I do things like huddle. I'll make sure we do a huddle, and every huddle I'll say, don't forget pharmacy can do this. I scrub patients constantly where I notice something, and I'll walk by the LPN and say, hey, I noticed his A1C was high. If you want, just walk him down and I can talk to him really quick. It's constant reminders, little tidbits, but so it's not overbearing, but just little reminders, hey, don't forget this, don't forget this. And I think the more reminders other providers outside can get, I think the more efficient pharmacy can be. And I think I would say that for other professions as well.
Is there a final comment? Please.
I think with everything that we've been seeing, we've seen yesterday and are going to see today, there's a lot of uncertainty in what we're doing. I mean, we're studying it. We're trying to learn better ways of doing it. And learning in this environment of uncertainty has been very helpful, I think, for the future. Because, as I go forward, I will be comfortable with that uncertainty and try to explore more. And so that's been a big benefit of learning in this environment where we're all trying to figure out how to do this best.
So my sense is, and we have to end here, and I wanted to thank the panel, but before doing that, I wanted to say that healthcare in the United States, at least, is in good hands if people like this move forward into intermediate and then senior leadership positions. So I think the program has been successful, but really it's more that you folks have been successful, because I can assure you, having been in on the design of this program, it now has nothing, it looks nothing like what we thought it might look like originally. And that's a testament in part to the faculty, but much more so to the trainees. So you really are the future. Go forth, multiply, and do good work. Thank you very much.